Welcome to Afya Clinic, your trusted space for conversation.
Karibu sana. This is MBCI TV ambapo tunabadilisha maisha by the grace of God. It's the 18th of February 2026 and we are here for Afya Clinic where we talk about health because health is very, very important. And so today we're going to be having such an amazing discussion. Yani today's discussion I don't want you to miss, but also I want you to sit, take your pen and paper or open the note app on your phone, because you're going to be having a discussion that you will need to know and understand very well. All right. So my name is Rachel Kahugu. We'll be here up to 10 in the AM, and today we'll be having such a great discussion. But before we get there, we'd like to know how your week has been so far since the last time we were here for Afya Clinic, that is last week on Wednesday. We'd like to know how your week has been, what you're thanking God for. So share with us through our social media pages, that is MBCI TV on YouTube, MBCI TV on Facebook, 0721-105-105 on WhatsApp, 23814, our SMS code, which is absolutely free of charge. We'd like to know, how your week has been, what you're thanking God for. Unatuwatch kutoka wapi, unatuwatch na kina nani, and we'd be happy to, read the feedback. Now, today we are having a discussion that is very important. As you know, what we do on Afya Clinic is talk about diseases, really. So if we are having, say, a mental health awareness month, we'll make sure that we talk about that. And we say that for mental health, we don't wait mpaka the mental health awareness month. We talk about mental health sana, because that's very important. But we've talked about many other things. We talked about malaria. We've tackled TB. We've tackled a lot of things. And today what we are talking about is how partnerships are improving access to healthcare. We'll break it down and make sure that you understand what that is, and make sure that today you understand exactly what we are doing. But for you to just have a rundown of what we are doing, we have a segment that we have for you that is the In History segment that will help you understand the history of healthcare. How was the healthcare in, say, 1990? And what is the difference between then and now? All right, so we get the In History segment, and then we'll be coming back as we continue with this particular discussion.
Hello and welcome to our In History segment. Healthcare has always been more than hospitals and medicine. It has been a measure of dignity, equality, and national progress. After independence, the government took on the huge responsibility of building a health system that could serve every Kenyan. Dispensaries were opened, hospitals were expanded, and communities began to experience structured medical care. But as the population grew, new diseases emerged and the pressure on the system intensified. By the 1980s and 1990s, the fight against HIV, tuberculosis, and malaria revealed the hard truth. Government effort alone was not enough. By the 1980s and 1990s, the fight against HIV, tuberculosis, and malaria revealed the hard truth. Government efforts alone were not enough. The scale of challenge demanded collaboration. International organizations, donors, faith-based institutions, and private partners stepped in, marking the beginning of a new era in the healthcare support. Then came 2010, a defining moment. With the new constitution and the introduction of devolution, healthcare became a county responsibility. This shift brought services closer to the people, but it also required stronger partnerships to sustain and expand them. Globally, the call for universal health coverage reinforced one powerful idea: no one should suffer or die simply because they cannot afford care. Today, partnerships are not optional, they are essential. They build hospitals, equip laboratories, train health workers, and extend services to the most vulnerable. And that history is what brings us to today's conversation, a conversation about collaboration, accountability, and the future of healthcare access for every mwananchi.
And so that's the history of the health sector, right from when we'd say it started. And so today we'll be talking about that. We'd like to know, and I know that we've asked questions, and so we'll be getting that later, but we'd like to know, how would you rate the healthcare system in Kenya? Yeah, so we'll be talking about that and we'll be able to understand your point of view. And for that, we'd like for you to speak to us, and we have shared our contact. Now, to help us tackle this discussion, we have the Chief Officer for External Resources in Nakuru, and that is Dr. Achoka. For you to understand who Dr. Victor Achoka is, we have the guest profile, so we know who he is and we come for the discussion.
Good morning and welcome to Afya Clinic, your trusted space for conversations that inform, empower, and transform your health and your well-being. Today, we focus on a very important conversation: how partnerships and external support are helping improve access to quality healthcare in our communities. Access to affordable, timely, and quality healthcare remains a major concern for many families, and partnerships between government, donors, and health organizations continue to play a critical role in strengthening our health systems, improving facilities, and expanding services, and ultimately saving lives. To help us understand this better, we are honored to be joined by Dr. Victor Achoka, the Chief Officer of External Resources. In his role, he works closely with partners and stakeholders to mobilize support that enhances healthcare delivery, strengthens infrastructure, and ensures that more people, especially in underserved areas, can access the care they need. He will help us understand what these partnerships mean, the impact they are creating on the ground, and what the future looks like for healthcare access in our county. So welcome with me on set, Dr. Victor Achoka. I'm your host, Rachel Kahugu.
Perfect, and we are back here with Dr. Achoka. How are you?
Hi, Rachel.
Good
How
morning.
Are you? Morning.
How have you been?
Thank you for having me on the show.
Asante.
It's pretty awesome.
Yeah, after a very long time.
Yeah, it's been a minute.
A very long time.
Asante sana.
Thank you for honoring our invite.
I would not have missed it for anything.
Yeah.
Yeah, true.
I know that today we're going to be having such an amazing conversation that I am really looking forward. In fact, since the last time we talked, or rather the first time we actually talked and decided that we'll have this conversation, I've been thinking through it, trying to understand this topic. I told you, yeye nimekuwa daktari.
You're actually doing an amazing job.
Asante.
You should be awarded recognition by prior learning.
Yeah.
You've learned a lot about healthcare just being on the show.
Msikize tafadhali. So for the people who are seeing you for the very first time today, please introduce yourself and tell us what you do.
Okay. I'm Dr. Achoka Victor Mwandale. I hail from here in Nakuru. I'm the current Chief Officer for External Resource Mobilization here for the County Government of Nakuru. I was appointed by the Governor, Madam Susan, sometime in September last year. And it's really amazing getting an opportunity to serve the people of Nakuru.
Yeah.
I've been serving them in many other capacities, but I think serving them at the public service at this level is actually something I'm very grateful for.
Yeah.
Other than that, I am a pharmacist, a Bachelor of Pharmacy. I also have a keen interest for the last 2 decades. I've been in the private sector. I've been managing a pharmacy chain and a health tech company. I'm sure you know about that, there's Endawa. And that's just before I joined public service. And I also serve among my peers. It's a great honor that my peers bestowed upon me the great honor of serving them as the Vice President of the Pharmaceutical Society of Kenya.
Yeah.
We are celebrating 62 years now. And that's
62, that's great.
Yeah, just after independence. That's when, we are well over 6,000 pharmacists, so I serve as the current Vice President.
Yeah.
Which is it's a professional society, it's a professional lobby group, looking at the safety and the efficacy of the drugs which our patients use. Essentially, we're taking care of the public. Father of 3, married, and probably, okay, I'm still a scholar. I did an MBA, because having been a businessman, I was trained as a pharmacist, as a drug dealer, you know. I was trained how to manufacture drugs, how to be able to dispense them, how to use them, how to do research and development. But after all that training, I still ended up in business. So I figured, why don't I study a little bit of business? So I did managing health business at Strathmore, then an MBA at Kabarak, and currently I'm still a scholar at Kabarak. I'm doing my Doctor of Philosophy there, still in entrepreneurial studies. And I was pretty lucky a couple of years ago. I got a scholarship to Purdue University, and I'm studying biotechnology, innovation, and regulatory sciences. Essentially, how to make how they did the new COVID vaccine. It was meant through biotech. I think that's the new age for pharma.
So how to make drugs?
Yeah, essentially that, yes.
Yeah.
But a
Good
very specific
drugs.
kind of drug. Yes, yes, yes. The
Please.
good types. Eh?
Yes, pharmaceutical drugs. Yes,
Yeah,
okay.
True.
Maybe let's start from because you're now the vice president.
Yes.
How would you say the pharmaceutical world is right now? I understand, and we talked about this earlier before, is that we have very many students who are graduating as pharmacists, and we have many people who've opened the pharmacies.
Retail pharmacies,
Yes.
Community pharmacies.
Community pharmacies.
Yeah, true.
So how would you say the sector is running right now?
Okay, so probably I'll funnel it at the global level. At the global level, we really are living in the golden age of pharma.
Yeah.
We really are. Yeah. Considering if we were to dial it back a little bit and go back to 2000, when you got the pandemic, the world shut down. And typically speaking, to develop a molecule from scratch to a drug which you can use in the general population in the market would averagely take 15 years to be able to do that.
Okay.
But check out what happened with the COVID vaccine.
Yeah.
We were able to come up with a vaccine in less than 2 years. And a lot of the research which is out there in the market, there are quite of published papers in very good journals which are showing that the effects of the vaccine actually are far much more positive than we even thought they would be. First things first, the world opened up again.
Yeah.
So it means the vaccine actually worked.
Yes. Yeah.
And for those who are naysayers, we saw people dropping dead. I have personal friends who died because of the COVID vaccine, because of the COVID disease.
Yeah.
So we know the vaccine worked. And thanks to the new technologies in healthcare, so biotechnology and other new technologies of drug manufacturing, we are seeing very rapid advances in pharmacy, in the pharmaceutical industries. In healthcare technologies and treatments, I'm telling you, there are massive advances. If ever, what the antibiotics that we're using currently right now, the newest, maybe the penicillins and that type of drugs, cephalosporins, those things go back to the 70s and the 80s. And those are the antibiotics we're using now.
Yeah.
But in biotech, we have things which are treating cancers which were previously untreatable.
Yep.
Yeah, even for the vaccines, we're seeing people going into remission thanks to having received the vaccine only. Because initially when they're doing this mRNA technology, they came across it when they're trying to develop some drugs for cancer. And that's how we have this vaccine that we have today.
Yeah.
So globally speaking, in the realm of pharma, we are really in the golden age of pharmacy. Yeah, it could never have been better. What we're doing right now, it used to take 15, 30 years to come up with. But these days, we're able to do that in the drop of a hat.
Yep.
But now if we come back home, now locally, now here in Kenya, it's booming. We're doing well. The shortage of pharmacists is still huge. Ideally, the WHO recommends that you're supposed to have at least 5 pharmacies in a population of 10,000, give or take.
Yeah.
But currently, we're still below 1 pharmacist in a population of 10,000.
Okay.
Speaking as pharmacists. And those are the statistics.
Yeah.
But being pragmatic and realistic, it's a little bit different. Now we have lower cadres of pharmacy. No, not pharmacists, people who have a diploma, and previously even had people who had certificates, which is still not, it's not yet recognized now, but at least the diploma holders, they recognize that.
Yeah.
And they are graduating in numbers. In the quest to try and achieve universal health coverage, they thought one of the bottlenecks is the workforce. So they decided to train as many people as possible. And they ended up now we have 92 KMTC, give or take, in the whole country.
Yeah.
Their graduation ceremony now is being done in, what stadium is this? In
Nairobi.
Yeah, Nairobi, on Thika Road. What's the name of that stadium?
There's still been in Thika Road.
Stadium.
The stadium yenye wanafanyanga graduations za...
Yeah, Kasarani.
Yes.
Can you imagine that? The graduation ceremony is being done in Kasarani. That's over 25,000 people graduating as diploma holders and other cadres. And less than 5,000 of these guys are being absorbed into the market. So what's happening? All these guys are going to private sector. And if you have to walk around town, frankly speaking, there are more pharmacy outlets, community pharmacy outlets, than butcheries.
Yeah.
So that makes you... So there's a challenge. The market is seriously fragmenting as opposed to aggregating. In a mature market, the retail segment aggregates. But ours is actually doing the exact opposite. It's running in the opposite direction. So quite a number of community pharmacies actually do have challenges as opposed to... They're not thriving. They're actually having... The exact opposite thing is happening, yes. So it's paradoxical that the sector is doing very well, but the entrepreneurs at the very small level, at the bottom of the pyramid, are struggling.
Okay. So what's to be done about that?
What's to be done about that? You see, a lot of these things have to stabilize over time. I think we've been in a transitional age. I saw on the the presentation that you did just before our show started about the history of healthcare. Yeah, we were working from a place of scarcity. That's how healthcare has been. It has always been. We've not been able, the government has not been able to provide fully at 100%. And that's why there's this big conversation, not only in Kenya, but at a global level, about universal health coverage. We need people, first of all, just to get access to healthcare, let alone good healthcare, let alone quality healthcare. The conversation right now in Kenya is about access to healthcare. In the Advent, yes, we had government facilities, and consider this, we're in a third world country. 100 years ago, people used to chew herbs. So that's changing. So fast forward to maybe the 40s and the 50s, people started going to clinics. And what was being offered there was very basic. As you see hospitals in Nairobi. Then the missionaries did a very good job. And thanks, kudos to MBCI and the organization that you work for. Even them, they've thrown their hat into the ring. They're doing quite a lot of community service. So, as we move into the 50s and the 60s, like you just showed in the show, so we've been trying to improve healthcare. So the missionaries, faith-based organizations have been doing their part. Missionaries have been doing their parts. The government has been trying to build more and more facilities. But we are chasing a moving target, and that has to be clear. So as we improve healthcare, as we improve the number of facilities, as we try and put more funding into healthcare, we are also increasing in population. Like I mentioned, we're chasing a moving target. This year we have over 140 billion the other year, which has been put into healthcare. But what's happening? There are more communicable diseases. The life expectancy is higher. So we have more people suffering from life diseases such as diabetes and elevated blood pressures. So it means that the disease burden is growing. As we increase more funding, the burden is growing bigger and bigger. And for various reasons. Like the life expectancy now is better. When I was growing up, the life expectancy was in the 40s. Being a black man in Kenya, getting to 50 was a miracle. And that is just in the 80s and the 90s. Right now, people are living well into their 80s.
Even 90s, in some 100.
On the average, we have 60-something as the life expectancy. So if you look at it that way, definitely,
I hear you. All right. And as you can tell, that's a whole other discussion there.
Yes.
But today we're talking about access to healthcare. And it's really amazing that you've mentioned about, in Kenya, we are talking about access to healthcare. Before we even talk about access to proper healthcare and everything that you need to get in a proper healthcare system. So today we're talking about access to healthcare. And as you said while you were starting, is that you're the Chief Officer for External Resource in Nakuru. What does that mean? And what's your job there?
Okay, so beyond my JD, what I do, when the governor, Madam Kehika, Her Excellency, gave me this job, I had served in other organizations where I used to help to resource mobilize. I was the president of the Rotary Club of Nakuru a couple of years ago, way back in 2015. And my core mandate then was just to look for resources to do community projects and services, rainwater harvesting, education, healthcare. So I had some history on that and my other credentials. So I think they put me into this position. So my role in the county government is that counties normally have a plan. The government works with plans and from the national government. So there's a document called the CIDP. It's an acronym. It's called the County Integrated Development Plan. It is a strategic plan, so to speak, about how our county needs to work for the next 5 years. So from the 2022 to 2027. So in this plan, we have provisions and aspirations of what we think we'd want to do. So they make provisions of what they think they'll be able to collect as a on-source revenue. Pesa ya parking, pesa ya land rates, pesa ya what the county collects. It used to be around 2 billion. It's been moving up, and right now we're about 3 billion, moving towards 4. Actually, we're doing pretty well. We are. Then after that, there's something called equitable shares in Ile Pesa, which comes from the national government. So they tax you for everything you buy. If you buy a loaf of bread, on a tax kidogo. You buy fuel, there's tax. This money is collected by KRA, goes to the national government, then it inagawanishwa kwa counties. They push it down into the counties. It's called the equitable shares. So we operate on a budget from what we collect locally and what tunapewa kidogo na national government. And that's why at times you see governors holding press conferences saying that we don't have money, something has to be done. So and that money comes, so we plan with that money at the county level, and we look at it, what are we able to collect every year for the next couple of 5 years. But when we do that, and with those estimates, vis-a-vis what we need to be able to do here at the county, make the roads, maintain, healthcare, pay salaries, ABCD, there's a shortage. So from the word go, we're already operating from a position of a shortage. And for Nakuru County, just from the plan itself, getting 100%, assuming you're going to get 100% equitable share, the national government is going to share 100%. Then we are going to be able to collect and fund ourselves as much as possible when we have everything. We are planning to spend 119 billion over this period of time, but right now we are hitting it. If everything goes according to plan, we'll maybe be able to spend maybe 104 billion, which leaves a gap of 15 billion shillings. That's just operational, 15 billion. So when we start this conversation as a county on how we're going to move forward, and every department has a budget and a plan, you already have a scarcity of 15 billion shillings in Nakuru County. That was the plan. And that was in the plan, in the CIDP, the County Integrated Development Plan. So to speak, like a strategic plan, or like a budget for the next 5 years, something like that. Then we have those flagship projects. Flagship projects are those things which are on the, and this is also at the national level and also at the county level. The aspirations of the governor. She wanted to make sure that you have a level 4, fully functional in every sub-county. She had to make sure Nakuru is a water scarce county. Almost 70 billion was just allocated just to make sure we have water. Access to clean water, which again plays into healthcare. Once you have clean water, again, that is already primary health care, waterborne diseases, ABCD, the story goes on and on. So there's that. So 70 billion, and that was the aspirations that our governor had. But guess what? We're halfway into the term. We've been able to do quite a number of those flagship projects. Maybe we're not able to rise that. And the budget for those flagship projects, we talked about the 15 billion shortage on this other end. On the flagship project, it's 99 billion. So essentially, we needed to raise almost 115 billion shillings. But you see, these are aspirations. When I say I'd like to build a spaceship, yes, so I wish to build a spaceship, so I'll try and work towards getting one. And those are just aspirations, like I said. So, but we've been able to achieve quite a lot of what we aspired to do. So my role is to look for that money, yes, for the county. So where do we get it from? We get it from state departments, we get it from talk to water bodies, to try and build the dams, to get water from Baringo, do the piping, get healthcare. We had, see what we can talk to the national government to get grants for purchasing of drugs in hospitals, because Nakuru takes care of far much more than the people of Nakuru. Our hospital is some sort of a referral hospital. And you can never turn away a woman who is in labor from
just because they're not from Nakuru.
Nakuru, yes. And how would you know that? There's no ID for Nakuru, So there's that. So essentially my role is to bridge this gap. Bridge this gap from partners, from the government itself, from the national government, etc., etc. I think that kind of explains what I do, And it's across all departments. Yes.
Now that we've talked about resource mobilization, and today we're specifically talking about, the health sector. You've mentioned about getting the drugs for the people of Nakuru, and this will apply for anyone in any other county.
True.
But for the people of Nakuru, would you say that the health system is getting enough drugs to serve the people, or do we need to do a little bit more?
Yes, there's always room for improvement. That much I can tell you for sure. There's always room for improvement. Someone saying otherwise would not be lying. But I'll tell you this much. There's a reason as to why we are victims of our own success. Yes, I can tell you that for sure. If you look at the number of ambulances of referral cases that we are getting from our neighboring counties, we are not only serving the people of Nakuru County, we are serving even our neighbors who previously probably had limited resources and did not have very well developed healthcare systems, healthcare delivery systems. So, and they tend to move towards the closest referral area. In Nakuru, we boast to have consultants in almost every domain. If you have to go to every department in our hospitals, you'd get a consultant in urology, a consultant in oncologist. In fact, quite a number of oncologists. And we have neurosurgeons. And it's also a teaching hospital for the medical school here at Egerton. So we also have subspecialties in our hospitals. So with the number of referrals that we have in our facility, let's say, for instance, in PGH, is overwhelming. There's that. So we budget for our people. We have our statistics. There are the censors. So the governor and the establishment plans for the people of Nakuru. But we are always pushed to the limits, and that's always inevitable. And probably that's why people might say we are not doing enough for them. But we really are. We really are. We really are. We, you know, if you have to look at our budgets, healthcare has been apportioned almost the largest recurrent expenditure.
Okay.
So we really are. But like you said, healthcare doesn't matter how much you plan, even in your own home. You never know when you're getting sick.
True.
You never know when there's an outbreak for something. So there's always that. But we really are. We, in fact, if there's a department which is doing a sterling job in our county, is the healthcare department. I can tell you that.
Okay. I hear you. Now, today, as we said when we were starting, is that we're talking about how partnerships are improving access to healthcare. And while you started, you said that as of now in Kenya, we are talking about access to healthcare, not access to really good healthcare. We'll get there. But we need to make sure that at least everyone is able to access healthcare easily. But let's start from the very basic. You know, while you talk about healthcare, there's someone who'll think about, oh my goodness, I'm sick, I need to go to hospital, and that's all about healthcare. What would you say healthcare is in layman's language? Okay.
Healthcare, if I was to put it in layman's language, is wellness. Probably that hiyo ni kizungu mingi, but I'd say just being fine, kukuwa sawa. I'm fine, niko sawa. Habari yako? Niko sawa. Kukuwa sawa, that's health. So there's more to it. There's more to it. See, kukuwa sawa is not necessarily the absence of sickness. I could be not having a headache or malaria, typhoid, or running stomach or something like that, but I am not well, meaning that I'm not sleeping well. I'm not able to settle. I'm having thoughts which are, you know, borderline suicidal or stuff like that. So mental health also comes into play. So wellness would be a good way to describe healthcare in its entirety. So for the layperson here, I think when we talk about healthcare, that's why it's a very thorny issue. And probably that's why you guys even have a show for healthcare. Because a regular person, there are a number of, you know, any Tom, Dick, and Harry, what would you be thinking about? You'd be thinking about what will I eat? So food security is number one. Have I eaten? And so what am I eating for lunch? What is there for supper? So we think about food. Other than food, people would imagine, okay, I'm not dying. You know, my grandmother is sick or something like that. So we think about our health. And the other thing, maybe education and maybe shelter. So, you know, kind of the basic things, the primary needs, so to speak. So healthcare comes there. So when we think about healthcare, we think about being alive. We need healthcare. But if you have to maybe add on to a little bit about this, do a deep dive into what I would imagine it is. As a pharmacist, it means that also being able to provide health technologies, things to be able to diagnose, things will help you to be able to measure your blood sugar, things that will also help you to measure your blood pressure, to monitor your health care, things which will be able to help you to prevent diseases. So all that is encompassed when you talk about healthcare delivery. You're supposed to be able to deliver these things. So it's not only about the doctor consulting, not only about nurses helping out in hospital. It's not only about surgeons doing surgeries. It's also about primary health care.
Now, when you talk about that and you've explained healthcare wholesomely, what are the gaps that are there in the healthcare system? Not only Nakuru, but Kenya in general.
The biggest challenge in healthcare, and that's what I think from the national government, from a policy level, they've been trying and resolve this. And keep in mind, we're a third world country. That's why the big conversation about going to Singapore. So the biggest gap in healthcare is healthcare funding. That is the problem. How much, if there's enough funding, if there are enough resources in healthcare, then everything else falls into place. If we have enough funding in healthcare, we'll be able to employ enough doctors in our hospitals. We'll be able to employ enough pharmacists in our facilities. We'll be able to have enough nurses, clinical officers, all other cadres. So funding, then with proper funding in healthcare, there'll be sufficient drugs. Yes. Okay. And not only just drugs which are, there's something called a formulary, whereby we just say, we consider the costing of drugs. And so probably the best drug to treat you for malaria would have been drug A. But because of cost issues, we just have to give you drug B, something like that. Okay. So we'll be able to give everyone drug A, like quality healthcare. Like I'm telling you now, that's quality healthcare. So if the conversation now is about employing more doctors, employing more nurses, employing more clinical officers, you see that now we've even moved away from, but we are trying, it's multifaceted. We are trying to sort out the HR issues, at the very same time also trying to make sure at least the basic medication in all facilities are available. Okay. At the very same, the diagnostic equipment in these facilities are also sufficient. So it's a play on all areas. Okay. We are trying to make everything work for us. Yes. So we are trying to moving forward. And if out of 10, I would say we are somewhere with a strong 7, 8 towards 10.
Is good.
Yeah, so definitely there's room for improvement, and that's why we have these conversations about partnerships.
And now we go to partnerships because it's one of the ways of solving the issues of resources around the healthcare system. So for the people who are hearing partnerships for the very first time, what are partnerships and how does that look like in the health sector?
So just to give you an idea, like from recent things which have happened recently, when the USAID program pulled out, here in Nakuru we used to have the other offices, like 3 floors somewhere, I think around the Nakumat building. What the USAID program was funding in healthcare is somewhere to the tune of around 470 million USD. That's a lot of money.
That's a lot of money.
Yeah, that was what was channeled towards healthcare. So you can imagine that money just going bottom up. You know? So it left a very huge gap. And a lot of that gap was in HR, because we had people that employed. But now what happened, the counties fell into place and they came to fill it up. But you see, that already puts a strain. That already puts a strain, not to us, not only to Nakuru, but to every other county in the country. That already was an immediate, and that's why it was very good news when we had the Washington agreement, when they'll be able to help out with that. So they're saying they're still going to fund us. So that was pretty great. It's pretty awesome. And we're looking forward to see how that's going to play out. One of the other biggest partners in healthcare is faith-based organizations. Yes. We have partners like we all are aware Kijabe, Tenwek. Here in Nakuru we have Mercy Mission Hospital, St. Mary's Hospital, and quite a number of other. Which, if you are to do, was almost 30%. So 30% of this, and it's not only faith-based organization. They're also fairly priced. They're reasonably priced. They also offer, they use SHA. So, and previously they still used to use NHIF, which is great. So they complement heavily what the government is doing. So as government is doing 47-something%, then we have faith-based organizations doing around 30%, give or take. Now we have the private players now filling up the rest of the gap.
Okay. And that's, I think you've explained it very well, because now we get to understand where we are coming from. As a country, with external resource and the partnerships. And so what that means is that we have people who are helping hospitals work better, and then that translates to you getting the services that you need in hospital. And so with that, we have Vox Pops, and this will help us understand the view of the people on this conversation that we're having today. And so we'll be hearing that immediately after that to come back to continue with this conversation. If you have any question that you'd like to ask around, the health sector in Nakuru or the county that you are in, feel free to ask. And for that, our questions are very open, or rather our numbers are very open. That is 0721 105 105 on WhatsApp, 23814, or SMS code, which is absolutely free of charge. We're live on Facebook on MBCI TV Facebook page, and on YouTube on MBCI TV official YouTube page. So feel free to send in your questions. We'll be coming right back. For now, let's take a look at the Vox Pops.
Kwa hii sekta ya health kuna challenge. Mostly sasa nye ministry ilibadilishwa ya health ikaleta kwa kulingana na hii devolution ikaleta kwa county. Unapata kama hizi county governments hizo zote zenye ziko so serious kuhusu hiyo health sector So unapata supply ya madawa ndio inafanywa mostly na maybe kwa county, unapata hakuna supply ya kutosha. Hiyo ni challenge number 1. Challenge number 2 ni kuhusu na insurance yenye imebadilishwa, of which hiyo sasa ni ya national government, kuhusu hii kitu yenye watu wanaita social health insurance ya SHA. Hiyo nayo imekuwa challenge, although ina work, haiwork kwa kila mtu. Sasa hatuyuko sure ina work aje. Unaweza pata umeregister, umefanya registration, umejiandikisha, umelipa na kama na hiyo mwaka moja, lakini ukienda kwa hospitali unapata haitakusaidia.
Challenges ni mingi kwa sababu ya kwanza unalipa malipo ya SHA na ukienda hospitalini hakuna matibabu, yani matibabu unafanyiwa lakini hakuna dawa. Second, hii SHA tulikuwa tunalipa mwezi. Sasa imekuwa ati lazima ulipe mwaka. Kama kwangu siwezi lipa mwaka kwa sababu mwaka nalipa 6,000. Hizo pesa ni mingi kuondoa hizo pesa kwa biashara safari moja. Kwa hivyo kwa upande wetu sisi kama hasura tunaumia na SHA haitusaidii kwa lolote. Kabisa haitusaidii kabisa.
It is worsening. In fact, afadhali NHIF, it is not helping anyone. Kwa sababu unapolipa, you see, I thought unapolipa whatever money, na kwanza wanaitisha pesa za the whole year. Na katika NHIF tulikuwa tunalipa 500 shillings every month. Ukipata shida unaenda hospitali and you are treated. And that is it. So these days I don't know what is happening. Actually we are like in a very lousy situation. Maisha yetu yamekuwa magumu. Sio afya, sio vyakula, sio anything. I think we are in a very funny situation. Yeah, and we are very discouraged. Wakati ambapo sasa unaomba Mungu tu usipate kugonjeka.
All right, so we are back, and that is what you have on the Vox Pops. What do you have to say about that?
Okay, so if I had them right, I think the two queries, if I was to generalize the first speaker and the second speaker, would be about the devolution of healthcare, how it was devolved, and the other issues was about health insurance.
Yeah.
Yes. So, like I mentioned a little bit earlier, I think one of the best things that happened to healthcare was devolution. I happen to have worked in the previous dispensation, well back in 2006, and I am in government right now after a small hiatus. And I can tell you one of the best things that happened to healthcare is how it was devolved.
Yeah.
But again, the speaker said that some counties are not a little bit serious with that. But in my preamble, when I was starting the conversation, I mentioned that we are chasing a moving target.
Yeah.
Yeah, we're chasing a moving target. As we invest more in healthcare, the load, what needs to be resolved in healthcare keeps growing.
Yeah.
And that's why now there's been a very deep emphasis on primary healthcare, trying to get many people not to get these lifestyle diseases. Because once you get that, we keep increasing our healthcare load. And this is happening on a global level. This is not just something local to Nakuru. So as much as we're investing more in healthcare, we are getting... So previously, and that's why devolution has been a great thing, all our resources were being controlled at the center. And if you are to see the number of facilities which have been built, I will use my county as an example.
Yeah.
Out of the 11 sub-counties, you're going to have fully functional and operational level 4 hospitals. We're not talking about just structures, we're talking about structures with medicine, with doctors and ABCD. Yeah. Yes, they might have challenges, but they are there and they are functioning. Yes? You can imagine that. Previously, everybody in Nakuru and in the surrounding used to go to PGH. We used to call it Medi, and you can bear me witness. And this is not a century ago. I'm talking about just 10 years ago. But look at Nakuru right now. In Bondeni here, we have a theater there. In Langalanga, you go to Bahati, you go to Kuresoi North, you go to Lengurwoni, you go to Bahati, you go to, go to Naivasha. We have all those very huge facilities with consultants there. In Molo, there are surgeons, there are pediatricians. These are people, just 10 years ago, you had to come all the way to Nakuru PGH and queue, probably be given a card after 2 or 3 days to come and see the consultant. But these days, you go to Molo and there's a pediatrician. You go to Naivasha, there's a pediatrician. There's a surgeon. You can have major surgery done in Naivasha and in Molo. That is something. At least you have to give it credit. So devolution in healthcare actually came with a lot of benefits. It came with a lot of benefits. And a lot of governors actually give a lot of emphasis into healthcare, specifically mine.
Yeah.
And they're giving a lot of emphasis into healthcare. So about the NHIF thing and SHA, because they were giving it a comparison.
Yeah.
I mentioned the biggest challenge in healthcare was funding. So what SHA was trying to do was trying to solve that problem by creating multiple funds. So there are social health insurance fund and a SHA. NHIF was just one fund. Yes. And NHIF, by the time it was ending, already owed the open market over 30 billion. So as much as people might say they were enjoying it, but it was, we were speeding at full speed towards hitting a wall. So I think maybe what could be happening right now, because you're in a transitional stage, is change management.
Yeah.
When you're trying to change from something old to something new, there are methods of how you're going to go about it. So there's a model, it's called Kotter's model, change management. Anywhere you just drop it. And so some people prefer transitional, some people, change is always hard.
Yeah.
But if there's anyone constant in life, it's change.
Yeah.
So the long and the short is this. If someone shows up in hospital today, yes, the patient would be operating under the premise that there has to be a doctor who's been paid, who's there. There has to be medicine, which has to be in the hospital. So even any other regular health insurance, if you had one, you needed to have paid a lump sum amount or paid for it in advance for it to be functional.
Yeah.
For these things to be there, waiting for you, they need to have been paid for. So quite a number of patients actually just register for SHA and they show up in hospital and they want treatment immediately to be covered for, and they've never paid for it. So like any other insurance model, which I understand is a very big challenge to quite a number of people, is that I'm just shown up today, I am sick, I want to be paid, and I want there to be medicine. The question would have been, where did these resources come from? For them, then you've just showed up today, you are sick.
Yeah.
I say I've registered for SHA, I want to pay 500 shillings and I want to be treated and be given all the medicine.
Yeah.
So you see, this medicine has to have been bought by the facility, because we're looking at counties operating independently or health facilities. Even if it's a private hospital offering SHA, they needed to have these resources into place. They need to have paid. So coming and not having paid for it and wanting to, so that's why they'd ask you at least to pay for a year. Because the probability is that if you come today, you pay 500, you're treated today, then you don't pay. Then the next time you show up, you say, I have SHA, then you pay on that day. So it creates some sort of, and that's why they ask you to at least pay for a year to try and make the model sustainable. Because the model is very heavily funded in people on pay slips. But if you have a pay slip, they'll not ask you to pay anything lump sum. You just get the treatment that you would require. But I think the biggest challenge with SHA is people showing up in hospitals and saying, walisema SHA yangu haifanyi. So we're also trying to solve another problem in healthcare. And that's why they created different funds. There's an emergency fund, different pots. There's one for hospitals like PGH. Then there's one for emergency and for blood. Then there's one for primary health care. And that's why now we have this conversation about a level 1 hospital, a level 2, level 3, level 4, up to level 6. So if someone sneezes overnight or you have a small fever and you show up to queue at PGH and somebody else, a small kid, has leukemia, so there are 2 mothers sitting on the line, 10 mothers sitting right in front of. There's one kid who had a convulsion, requires to be admitted into the ward, and another kid is sneezing, and all of you are queuing there, and you want to see the same doctor. So they are telling us, or rather the argument here is that the kids with colds and sneezes and things like that, don't go to a level 5 or level 6 hospital. Don't go to PGH. There is a dispensary in Langalanga. There's a dispensary in Ronda. If you live in Mulimani, there's a dispensary there. If you live in Muzawanyama, there's a place there you can go. So, but for a lot of people, they wake up with a sick kid, and because they know that the best services for healthcare in Nakuru are in PGH, they walk to PGH. But you see, in this new model, we're telling guys, look at it this way. We are funding healthcare differently. You go to PGH when the person at your dispensary or the health center has escalated your need to there. So when SHA tells you no, there is a fund that we have in place at the dispensary to help you there. And when you go there, you will not pay. You will just be treated and you walk away. But the patient, so when you go to PGH, they tell you no. At a level 5 or at a level 6, you cannot just, you need to be referred. You need to go through the system. And this is a global practice. It's a global practice. You go to South Africa, you go to Spain, you go to Europe, in America. Healthcare is graduate, even in the UK. You don't just show up and you want to go and see a consultant dermatologist because you have a pimple on your face. They tell you no. Even if healthcare is free there, you'll have to go to your GP, then the GP escalates it over time, before you go and see the consultant.
Yeah.
But the practice has been in the past, so NHIF allowed for that. NHIF allowed for you to go to any facility, you just go to PGH and ask for care. But you see, again, what that created, it created a choke. And, there was a bottleneck at PGH, whereby now services in PGH were becoming unattainable. I'm not talking about PGH, I'm talking about Kenyatta National Hospital. I'm talking about Moi Teaching and Referral in Eldoret. There was that challenge. So at a primary healthcare level, you'd hear people complaining about SHA.
Yeah.
But the long and the short, these are budding issues. This will take a minute. I know it's something very emotive with a lot of Kenyans.
Yeah.
But I think it's the whole idea of change management. And you see, when SHA was being introduced, there was a lot of controversy around that. There are people, when NHIF, it was being called almost being, they are being closed. There are people within that had issues. And I think the people who needed to really have championed the transition of SHA would have been doctors.
Okay.
Because doctors understood it.
Yeah.
Nurses understood it. The Pharmaceuticals Society of Kenya understood it.
Yeah.
Kenya Medical Association understood it. So we should have had a better conversation about that, but we chose not to. I think, I don't know what happened around that time, but I think people need just more information about this.
Okay. Well, you were starting, you mentioned about the issue of disseminating information in the health sector, and you said that could be one of the issues that the health sector in Kenya is facing, that the public are not able to get the right information or the information that they need to get, not only about SHA, but the health sector in general.
Yes, it's true. Actually, communication is actually a very big issue. Yeah, I had one of my lecturers some time back. He's a researcher, so he went to quite a number of. He actually went to all level 4 and level hospitals in the country. So it was a very extensive research.
Yeah.
And his research was actually something very interesting. He said he was trying to find out what quality healthcare was. So, as doctors, we understand what quality healthcare is. Quality healthcare for us is clinical outcomes. Mtu kupona. You are sick, you go to hospital, and we treat you, you get well. But to patients, apparently quality healthcare is something else. So quality healthcare is how I was treated in hospital. I went to hospital, I went to see nikaambiwa shida yangu ni nini. The nurses were kind, the food was good in hospital, the hospital was clean, and ABCD. So how we define quality healthcare as medical practitioners apparently is very different from what patients describe it as. So patients will say that was a good doctor because he talked to me. He explained my condition to me. He was able to tell me what to eat. He was kind, the nurses were nice. So communication, and I think this one it is our problem. Healthcare providers, that's where we struggle. For us, we know, we've tested you, we know what your problem is. Shika shinano enda zako. So this one, I'll blame the healthcare providers fair and square. This is something we really need to improve on. If there are people who are really, really bad at communication, when people say you queue at the doctor's office, you go there and you sit for hours, as opposed to doctors telling patients, I'll not be in, I'm in theater, I'll be late. Just simple things like that. No, they just, just queue there for hours and hours.
And then you realize it's not coming all together.
A nurse just injects you. They don't tell you
what the problem
is. They don't even explain this to you. So I think it's something, as healthcare providers, we really need to improve on how we communicate to our patients and how we communicate to the public. And the moment we'll be able to do this, a lot of the challenges that we are perceived to be existing in healthcare will have been resolved.
Okay. I hear you. Now, the question I'd like to pose to you as you take this very short break is that what is quality healthcare to you? As Dr. Achoka said, is that clearly the meaning of quality healthcare is different with the patients and with the healthcare providers. But we'd like to know, in your perspective, what is quality healthcare, and are you able to get quality healthcare from where you're at? Okay, so we take a very short break. We'll be coming right back. This is Afya Clinic, and you are watching us on MBCI TV. My name is Rachel Kahugu. Today we're here with Dr. Achoka. We are speaking about how possible is it for you to get the healthcare services that you need in Kenya, in Nakuru, in Nairobi, wherever you're at. All right? So a very short break. We'll be coming right back. Usende mbali.
Thank you.
MBCI Television, transforming lives. Yesu itayanje, tayanje, Yesu tayanje, tayanje, Yesu, Yesu mwana wa Nyasaye tayanje, Yesu tayanje, tayanje, Yesu, Yesu mwana wa Nyasaye.
Transform your sanctuary with high-quality church chairs designed to bring comfort, beauty, durability, dignity, and elegance to the house of worship.
Eshkol Furniture Solutions presents a church chair with a strong frame, crafted from pure virgin metal for exceptional strength and durability, and coated using high-pressure, high-temperature painting technology to resist scratches,
giving the chair a shiny, long-lasting look. This elegant and comfortable chair design comes cushioned with high-density foam, guaranteeing the comfort of every believer during church programs. Available in a wide range of colors to complement your church theme, with the option of embroidered logo for a distinguished touch of identity and elegant look. Replaceable seat covers are also available on order. The chair is built with practical functionality in mind, as it comes with an option for under-seat rack, perfect for holding Bibles, hymn books, or personal items. Its studded size saves space and allows for easy stacking, with protective plastic pads to prevent clutching. It's simple to arrange and offers flexibility for any church setup. Upgrade your sanctuary today with these premium church chairs. Prioritize the comfort of believers, beautify the sanctuary, and restore dignity of the house of the Lord.
Order today on 0757 444 333 or email us at eshkolfurniture@gmail.com. Eshkol Furniture Solutions. Passion for excellence.
MBCI Television, transforming lives.
All right, we are back. Thank you so much for staying. This is the right place to be. This is MBCI TV, ambapo tunabadilisha maisha by the grace of God. And today we are here for Afya Clinic because, as we always say, is that your health is our priority. And so we get to speak about what you would do to make sure that your health is iko sawa. And as we always say, that as much as we talk about all this, is that your health is your responsibility, really. So make sure you do what is right for you to be okay. Eat well, and I know Dr. will tell us about it. Take clean water, take a lot of water. As much as we're talking about improving access to healthcare and quality healthcare for that matter, is that for you to need to go to hospital as an emergency, is that there's a history, something has happened. So if you can, take care of yourself, take care of your babies, take care of your family, eat well, a healthy, balanced meal, just to make sure that everything is okay, all right? But even with that said, is that today we're talking about how partnerships are improving access to healthcare and how we are able to access healthcare in general, and what that looks like, what happens when you go into a hospital. That is what we've been talking about today. And Dr. Achoka has been helping us go through it. And I know that you've been able to get something from today's conversation. If you have any question, feel free to ask through our WhatsApp number, that is 0721 105 105. We're live on Facebook on MBCI TV. We're live on YouTube on MBCI TV Official. Today we have the Chief Officer for External Resource in Nakuru, that is Dr. Victor Achoka. Thank you so much for being with us today.
Thank you, Rachel. Always a pleasure to be here.
Yeah, we've had a very wholesome conversation and a very informative conversation for that matter.
Thank you.
You've talked about so many things. I see we have very many questions about SHA coming in, and I know that you've been able to talk about it. If you still have any other question, or if you've not been able to understand something, feel free. We'll be able to ask the questions and get answers for what you need. Now, one of the major questions is that what should we do if services meant to be free are not available?
Okay, there are So there's maybe just as a preamble, there's nothing for free. Let's just understand that first. Something's got to give you. Any resources are not infinite. Everything you can't have. So, but we have social programs. Like in healthcare, there are social programs. So at least for the bare minimum, you need to be registered for sure. Once you are registered for sure, then you're able to receive. But there are certain services which are supported by the collections which are normally given to SHA, like things like vaccination. Somebody funds that. For all the vaccines that we get, when a child is born, they get polio, they get... So the assumption here, those are supposed to be free services. No, there are people working very hard to fundraise for those services. When we've even had a walk here in Nakuru town. We got small kids to do those performances, like 10 bob, something. We had a walk and polio now. So the polio vaccine that people demand, get in facilities, that's not free. Some people raised money for that. For every shilling raised by Rotary, 2 shillings are matched by the Bill and Melinda Gates Foundation. Then it's a little bit is matched by the WHO, and that's how you get the vaccine that you get in hospital. So there's nothing for free. There are people who work very hard to raise those resources to be able to get them for the people. So, but I know this is the thing. Nobody plans to be unwell. You see, nobody plans to be sick. I think I'm going to have a heart attack next month on Tuesday. No, we don't do that. But for the very bare minimum, what we could do, we could plan to be well. You get that? So I think I could give you a plan on how to plan to be well. Having some sort of a wellness program, exercise, good diet, food, regular checkups, ABCD. Those things are free. Like we have camps as well where you can be going, just making sure you're in good health. But like I said, resources are constricted. And that's why people like me have jobs to go and look for those resources. Yes. And in our healthcare facilities, we offer, like in Nakuru for sure, I don't think we have any gap anywhere. Or in our HR, the issue here is the numbers. Not that we don't have them, it's just the numbers. We have consultant physicians, we have cardiologists, we have neurosurgeons, we have oncologists in Nakuru, we have ENT surgeons, just to go on and on and on. And we have people with almost all subspecialties in Nakuru. We have pharmacists, we have clinical pharmacists, we have people, so they are all there. But at times when you go to these facilities for one reason or the other, maybe someone might not be available, or a certain drug which they would have preferred to use as opposed to what's available is not there. At times, you see, that's the thing. Quality healthcare, as defined for a patient, mimi nilienda hospitali, you gave me medicine. I left there carrying something. But at times the doctor would be like, okay, I do have this antibiotic in the hospital. I have probably, let's say, amoxicillin. But for the infection that you have, I think you require something slightly better. You require a drug which has probably better efficacy, would work quicker for you, or would give you better clinical outcomes. So the patient, to them, anataka apewe tu dawa aende nyumbani. And be honest, if I die, ni mambo ya Mungu. But for the doctor doesn't see it that way. The doctor is looking at giving you quality healthcare. And the doctor is defining quality healthcare as clinical outcomes. Me, I would want you to have this and ABCD done. Not just anything, but ABCD done. And when we are budgeting, just to make sure at least kuna dawa ya all the basic diseases, we're just budgeting that at least we have a doctor, we have a diagnostic equipment. But the doctor who is sitting there feels as though you probably require something a little bit more enhanced. Something a little bit more enhanced than what he has to offer in a public facility. And when patients are told as much, probably with not very good communication, to them, they'll argue that hii hospitali hata haina madawa. Hii hospitali ni mbaya. Nilienda tu akaniambia niende ninunue dawa town.
So wako na dawa but hawana dawa yenye itakusaidia
because of the
clinician,
the clinician or the doctor feels that whatever they have to offer in the facility, which they had budgeted for and planned for, is probably not good enough to be able to give you the best clinical outcomes. Yes, and how they would see ati hapana hii ni njama, the doctor and the guy in the pharmacy in town, they have colluded to make sure. So for instance, if you go to any health facility, there's medication for blood pressure, elevated blood pressure. For basic. But there are people who have chronic blood pressure. There are people who have blood pressure with other underlying conditions. So how I would manage somebody who just walked in with blood pressure is very different from how I would manage somebody the blood pressure has been sustainably high for quite a number of time. He has other underlying conditions. So the clinician feels I think there's this other drug which would give you better clinical outcomes as opposed to what we have in hospital.
So they ask you to go buy that.
They ask you to go and buy that.
Okay.
But the patient would be like, pana, why are you not giving me medication? You should have medication for every type of... but you see, when you're budgeting, we budget for the average, for the median. The majority of people, they just have controlled blood pressure. So you make sure you have medication for controlled blood pressure.
Okay.
But somebody comes with a different type, you know, something slightly different. So they
you have to get
and then they will still argue, wewe hauna dawa.
I hear you. And what I'm getting from what you're saying is that the public are actually benefiting from the partnerships and what the government is giving in hospitals. It's just that what they're doing is making sure that you're well, at least on the basic.
On the basic.
Okay,
at least when we plan, and that's why we have something called a formulary. A formulary looks at what we have 100 patients. What would 90 patients require? So we buy that. What the 10 will require. So because also economies of scale. Yes, something like that.
Okay.
So you plan for the majority.
All right. Now I'd like for us to take a look at some of the myth busters to demystify the myths that are around the issue of, you know, healthcare facilities, access to healthcare, you know, the issues of funds in the healthcare sector, because we have a lot that people talk about in the healthcare sector. And so one of the mythbusters is that donor-funded healthcare services are always free. And so we expect, kama serikali imesema tumepewa dawa, and now you can get it for free, nikienda hospitali, if I have any issue, expect you to give me medication for free. And you've talked about that.
So donor-funded programs, some are free, but a huge majority of them are highly subsidized. Take, for instance, the medication that is required to treat you for malaria. The AL medication, when it came to the market, a dose, a 3-day course would cost almost 1,000 shillings, give or take. But due to substantive funding from Global Fund and many other partners who came into play, the costing of these malaria drugs at some point went down to less than 50 shillings. So the 50 shillings caters for logistics, yes. So we have donor funding, which has made sure the drug itself is almost 1,000, but it's being sold now for 50 bob. So technically speaking, the drug is just free. The 50 shillings is just to make sure the last mile delivery, kufikie wewe, something has to be paid for. So the assumption that your dawa malaria tunafaa kupewa bure, and that has done a very big difference. Malaria right now, it's not as... the number of deaths that you're recording for malaria is not as bad as they used to be. You know, I grew up in a malaria endemic area, and believe me, people used to die from malaria. These days, you hardly ever hear of that. Recently, we have a few strains of papale, but But anyway, things like HIV medication. HIV medication is free. You're given the drugs for free. So the only thing that the challenge is you go there and the other opportunistic condition, diseases, maybe something else come up other than the ARVs. But for the ARVs itself, that program is very well funded and you're going to be given the drugs as such. Now the issue is the people who will be able to take care of those patients. So the HR issue. So which we are being helped in a very big way by guys like USAID and stuff like that. We had quite a number of clinicians taking care of those clinics. We had quite a number of nurses. We had people who were doing counseling and stuff like that. Now, that's a budgetary gap which we've had now to fill out now as the county governments.
Okay. I hear you. Speaking of malaria, and I know that we'll have another session where we'll talk about that specifically. Lately, we've had issues, 1, 2, cases in different counties that are not even, malaria endemic like Nakuru. What could be the issue? What could be happening?
So I happened to have been in a meeting like 3 weeks ago where that was actually the conversation. Kenya is doing pretty well in the whole idea about controlling malaria. And our aspirations were quite big. What we are looking at doing as Kenya, we're actually trying to make malaria no longer endemic. There are places like in Kenya, like Nyeri. Nyeri is malaria free. And if someone gets sick with malaria, but there are cases like Dedan Kimathi University, a student there whose home is in Siaya, was in Siaya 3 or 4 weeks ago, maybe did not take a good course of antibiotics, something like that. Then they're in Nyeri, then they go to hospital and they have malaria. So we're having such sporadic cases at Papale, but there are counties which are doing quite well, Nakuru included. although right here next door we have started seeing some kidogo strains of variants to resistance kidogo. But as a country as a whole, we are doing pretty well.
Okay.
And that's one of the big battles as a country we've been able to win.
Okay.
We are winning. We're on the winning streak, and we are hoping to keep it that way.
Okay.
Yeah.
I hear you. Our second myth, Pastor, is that external funding replaces the government's responsibility.
Resources are never enough.
Yeah.
Even in developed country, even in America, where there's Obamacare. Yeah, you'll get free help in ERs. You have a fracture, they'll just fix it and ask you to leave the emergency room.
Yeah.
As opposed to keeping you, to keeping you in the hospital for a number of days because of funding.
Yeah.
Of funding. Believe me, the biggest problem in healthcare is the number. And so if someone was to tell you that there's enough money for that, that's not true.
Yeah.
I started by telling you what my role was and telling you how big the budgetary gap is. People don't know about that.
Yeah.
We still have to pay. We have over 6,000 permanent and pensionable employees at the county. If you add the other workers, it's over 10,000, give or take. Those are salaries which have to be paid every month.
Yeah.
You have to maintain all those offices. You have to be able to stationery, even just printing licenses for people, that's stationery and stuff like that. So being able to and consider what counties are collecting and vis-a-vis what you're getting from the national. So even before we think about development projects, even before we think about reticulating water across the whole county, everybody in Maimahiu and Gilgil wapate maji, everybody between here and Kambiamoto wakuwe na maji. Just thinking about that, and you're talking about shortages in, before you think about that. So you can imagine, we already had a 15B, then you add this. So as a county, even being able to do what we are doing right now, doing hundreds of kilometers of roads in rural areas, because as we think about doing Lami, you can imagine there are places which don't even have roads. So that has to be done first.
Okay.
So now take that also into healthcare. So resources are not infinite.
Yeah.
Yeah, they're limited.
Okay.
Yeah.
And the third one is that only big hospitals benefit from partnerships. Is it true?
Actually, the biggest partners in healthcare is in primary healthcare. Programs like for things like surgeries and stuff like oncology, those things you have to pay for. But things like ARVs, they're given in dispensaries. Testing for HIV are done uko mashinani. If you have to go to Molo, if you have to go to Lengoroni, if you have to go to any kitongoji in the country, you'll be able to access those primary healthcare. Anti-malarials are available in every village in Kisumu, in Siaya, in Budalangi, in Wapi. And the reason they are accessible there, treated nets and stuff like that, is because of partners. So partners play a much, much bigger role in primary healthcare than they do. But it still remains the role of the government in a very big way to be able to offer these services.
Okay. I hear you. And the other myth, Pastor, is that funds from partners are never accounted for.
If there's anything that needs accounting, far much more, which are audited more rigorously than the regular ones, is actually donor funding. Even issues just like the procurement processes in donor funds, I'm sure you saw that in the news, and the issue about purchase of condoms, purchase of nets and stuff like that. Those ones are highly, highly regulated. In fact, they're not even audited internally. We audit ourselves on commodities and how, in the facilities and everything, but they have their own internal controls. Very, very rigorous. So it's as you say, that's just a myth. Yes.
All right. And the last one that we look at today is that when donor funding ends, services completely collapse. Has that happened before?
Donor funding ended. Did services collapse? Did services collapse?
Not really.
No, we filled in the gap. We stepped in and we were able to do the job. Yes.
Okay.
Yes.
I hear. So that's a myth. All right. So if I walk into a public hospital today, what difference would I see seeing that we have these partnerships happening? And like Kitambo, before, as we started by saying, is that in the 90s and 80s, we really did have these partnerships from faith-based organizations and, other organizations. So what changes are there now? That
something which is very visible if you're to go down memory lane. Yes. Okay, first things first. HIV was a death sentence. It no longer is.
Yeah.
True or false?
True.
Yes. And our staff members. We have partnerships, like in Nakuru recently, a partnership with the AMREF, partnerships with the Global Fund, partnerships with a lot of healthcare. In fact, at the primary care levels, even on the commodity itself, and even on the support and training and capacity building. Emerging issues like antimicrobial resistance, whereby we used to have antibiotics which would work to treat certain conditions, and they're not able. So right now we are seeing even in TB, we started having those emerging cases of resistance and stuff like that. All that is being curbed. And this is, a lot of this work is from the help of partners. Here in Nakuru, we have a very big campaign on antimicrobial resistance, very vibrant, which is happening in our facilities. Now we are seeing drugs, rational use of antibiotics. You can see those in our facilities. We can see access to antiretroviral medication across all our facilities. We're able to see testing. We are seeing placement of equipment. Like you said, 2 decades ago, just to have an MRI, they had to ship you to Nairobi. Right now, we have it in our facilities. We have CT scans in our facilities here. And I'm talking about government facilities. And this is in a very good way, thanks not only to the resources that we have as a county, but for some of the partnerships that we're having from the Ministry of Health, from the national government. Right now, we are seeing our trauma center. Like I told you, everybody traveling across the country from Western Kenya, we're talking about a population of over 20 million plus on this other side of the country. They all use this road going up country. So the number of accidents on this road, it's all over in the news. And where do all these guys go to? PGH. So we are building an ultra-modern trauma center, but this is thanks to partnerships that we're having with the Ministry of Defense and the national government. It was a project which was started out by Kibaki. Can you imagine that? And it's told because of funding. Like I told you, because now the issue was, what was the bigger issue? The women giving birth in Nakuru, do we set up the Margaret Kenyatta Center, or do we use these funds? So you see, the governor at that time decided, okay, let's put more emphasis on childbirth as opposed to the trauma center. But right now we are realizing that it's still a problem as it is. So we resourced for that. The governor went out of her limb. She's able to resource for that. And that's what we are doing right now. So that's almost complete. You see, so if you go to PGH today, you'd see at a very advanced stage, the trauma center being set up. You'd be able to get a lot of those vaccines free across a lot of our facilities. And the assumption would have been, they used to be free. But how many kids were being born then vis-a-vis today? The burden is becoming bigger and bigger. Like I told you, we are chasing a moving target, yes.
Now, for someone who's watching us from the village and the child gets sick and they go to hospital, what's the advantage they'll get now that you have these partnerships?
Okay, I would start when you visit like a village, let's take for instance in Lengoruoni, with a sick child. If you go to hospital, the first thing we'll have received preventive services. The vaccines will have been gotten for free. Yes, let's start there. And secondly, the mother in that village will not have had to walk a very, very long distance. The hospitals that we are building, in this level of hospitals that we are building in these sub-counties, they are thanks to the partnerships that we are having with programs like KDSP, the devolution support programs, whereby now we are able to resource and be able to build facilities in Njoro. So the first advantage is access to healthcare. The patient doesn't have to travel to Nakuru PGH to get treatment. They get treatment in Njoro. You get it? So as a county, we've been able to set up a facility there, and thanks to the partnerships that we're having. Yes.
I hear you. And I think that's very important for everyone to know that as much as we're discussing, and even as we are discussing about healthcare, one of the major strides that we've seen in the healthcare sectors is that we've been able to get, at least for what I know, and you'll tell us about it, to get healthcare services and structures in a very close range.
Access.
We'll
First things first. Yes.
So from one hospital to the other, ni karibu sana, which means from where you're at,
it's
easier for you to get to hospital. And the referral systems.
Yes.
How's that working currently in Nakuru?
So the referral systems are spot on. We have a very well networked system here in Nakuru. like I told you, I think the issue here is just disseminating this information. Everybody gets unwell, they want to come to PGH for treatment. I think that's just the issue. And you cannot blame it for them. Everybody wants the best for themselves. If I know that's the best restaurant in town, I want to go and eat there. Why would I eat in a kibanda and I can afford the best restaurant in town? So it becomes, the tables are full there. The very same way. Everybody wants to go to PGH because they know it's the best facility. So they'll flock it.
Okay. People are still complaining about queues and waiting for a long time in the hospitals.
So queuing times, that's a challenge across the board, even in private facilities. If you have to go to Aga Khan, Nairobi Hospital, there's still queues, and you don't walk in and see the doctor. And the problem is inherent because nobody schedules sickness. You see, if I knew I was going to get diarrhea on Tuesday morning, I would plan for it in advance and probably go early to hospital. But you wake up on Tuesday morning, so you rush there, and that's for everybody. So being able to schedule everybody. So queue management in hospitals has always been a challenge. And that's why there are quite a number of innovations on how to go about it. Having a triage, having nurses actually coming to stand in the queues themselves and pick out patients who look a little bit sicker than the others. So that is, but the other way we've been able to try and manage this is also having hospitals closer to the people, creating access. So when somebody over time realizes, okay, I'm unwell, why should I walk all the way to PGH and there's this facility here? They just go to the nearest hospital. And that is something which we are working towards resolving, yes.
Okay. What did you want to give partners who are supporting the healthcare systems now?
So partners, I want to tell them that what they need to do is to also, when they are looking at people to partner with, they should see that the output. Yes, what are we able to do with the resources that are being given to us? How accountable are we? How accountable are we for the resources that are being given to us? What is the impact that we are giving to the community? Many of them actually do have very robust monitoring and evaluation, follow-ups. They'd like to see the impact that they've done to the community, how they've been able to transform the communities around them. And that is very evident here in Nakuru. It's evident because you can see the growth in the population, meaning that as the population grows, it means they are healthier. The life expectancy is getting better. The clinical outcomes are better. Yes. Despite the noise that you might be hearing in the other quarters, but the truth is in the numbers, in what you're able to observe and see. Why else would the hospital be full? Why would someone choose not to go to Eldoret or go directly to Nairobi but come to Nakuru? There's a reason why, isn't it?
They're getting good healthcare.
Yes. They really are.
And on that, what would you like to tell the viewers, or what would you like the viewers to understand about the healthcare system in Nakuru and Kenya in general? And secondly, about partnerships.
So we need to build more bridges. That's granted. We need to work a little bit more closer. We need to be more accountable to our partners. We need to be able, you see, when the USAID program pulled out, when Trump said, let's make America great again, they really downscaled on the funding that they are giving to USAID. And this was done at a global scale. But we are the first African country, actually, where they said, okay, you guys are doing a good job. Let's go back in there and see what we were able to do there. And they had their reasons to do that. Why else did they do it? There was no quid pro quo as such. That is 100%. Those are grants. That's aid. So being accountable for what we do actually plays a very big part to fostering more relationships and growing more partnerships. And it's not, I've spent quite a number of time talking about the USAID program, but we also have other partners in healthcare. We have people like JPEGO, people like AMREF, like JPEGO is from Japan. We have guys from the German government. Quite a number of, even in India, we have partners from India who are actually assisting in healthcare in Kenya.
Okay. And now I know we've mentioned about this before, we have very many questions around SHA. And I know apart from SHA, we have other ways of going about, funding for healthcare on a personal level. But for the people who have many questions about SHA, what would you like to tell them?
Okay, so change is normally a challenge. And the people have argued, why wouldn't we improve on what was existing? Why did you have to start something new? They have to understand that what was the problem then. It is in human nature to be very nostalgic. Yeah, it's very nostalgic. The good old days.
Yeah.
So people are talking about the good old days of NHIF. Nobody's talking about all the facilities which closed down because of the struggles that they were having then. I was there. I was there in the health sector. And I'm telling you, we still had bills which would go on for years and years to health facilities which were not being paid.
Yeah.
I was talking about the insufficiencies. And we were working with a model which had been there from the 70s and 60s. I can't remember how old it is. But we're also looking at a moving target. The population is increasing. Yes. And people, lifestyle diseases are becoming more prone.
Yeah.
We are looking at issues like managing cancer. Our diagnostic techniques are better. So things which we never used to pick up in the past.
Yeah.
People would just die in the villages. But now we know at least they have cancer. And we try and do something about it.
Yeah.
Issues like dialysis. Nakuru did not even have a dialysis unit 20 years ago. You can imagine that.
Yeah.
See, at Kitambo, like, when I was working at PGH, there was no dialysis there. So you see, we needed to think more innovatively. We need to think differently.
Yeah.
We have to think outside the box. And the only way we do that is to increase healthcare funding. And keep in mind, we are a third world country. I think people keep forgetting this. Our resources are not finite. With Dagio, there's corruption, there's ABCD, there's all that. But even if a single shilling still never disappeared from our system, we are still not able to fund healthcare in its entirety. Yeah. So there will always be gaps in healthcare funding. Yes.
Okay.
So NHIF's transition to SHA was looking at improving the funding.
Okay.
Yeah. Funding and service delivery. Meaning that there are levels of care.
Yeah.
There's level 1 of care, level 2 of care, level 3 of care. Then we fund level 1 care differently. We fund level 2 differently. So on paper, it's a perfect. On paper, SHA is perfect.
Yeah.
It's at 100%. So the issue here is just maybe implementation, communication, people understanding how it works, people seeing the values in it. When you look at something as glass half empty, not as glass half full, it will definitely be a glass half empty kind of a situation.
Okay.
Yeah. So it's also been a little bit politicized, even when there are certain gains, certain benefits, which I would like to communicate. The good voice is always drowned out with other sentiments. So I think at times someone should probably, when you want to use it, and the question should be to a lot of people is that, what alternative do you have? That's what's existing right now.
Yeah.
Complaining about it won't solve it. It's probably trying to understand it. So let's just have a look at it. Let's see if we can be able to understand it. Let's see how it gets to work. And people don't like change. It's inevitable. It's in human nature. But just let's look at what is existing now. Let's see how it's working, and let's try and understand it, and let's see how it's going to work towards our advantage. Let's talk about, the discussion should be of how should we improve it. Not that, I'm not going to pay for it.
So tuachane nayo.
NHIF used to be 6,000 a year. SHA is 6,000 a year. Yes, like the call aspect. Why do they ask me to pay for the whole year? The reason NHIF was struggling is because you show up to hospital and you want to be treated there and then. Like I tried to explain that a bit. So they're trying to make this a little bit more sustainable. If you're going to be insured, you're going to be paying for the insurance every year. Not only when you are sick. No.
Every year.
Yes.
So then when you're
That's
sick,
how insurance
it will help
works.
you. All right. And maybe just to throw it in, if, and this is very important, if you're able to also just pay for other insurances, just to make sure that you're covered all round, but start with SHA, because, it's there. It's there to stay, and maybe on a personal level, I'd say, as you've said, try and understand it, try and work around it, because really, what other option do we have? So try and work around it.
True.
Now, where can the public, and we like to get information, so where can they get the right information about the health programs available?
Okay, I'm really hoping that we'll be able to invite our CEC for Health. She's a wonderful lady. She does a very good job. So that would be a good place to start at our healthcare offices. If you're thinking probably you didn't get the services that you'd require, you could. Our offices there at the county. We have an open door kind of a policy. Even through our socials, actually, we get to see what people are writing and complaining about through the socials for the county government of Nakuru. If you have you'd be surprised at how often people contact the governor. People have a number. At some point she complained vile tumemtumia shilingi moja. People could not believe it's her number. So they kept telling her one bob just to make sure it's her number. So people have access to her. But obviously the best way to go about it is that in every facility there's a help desk. There's a help desk there. You are right. There's nothing here. It's your right. Just go there and ask. You can always ask to see the person in charge of the facility. No one stops you from doing that.
Yeah.
There's a service charter in every facility. In fact, it's even mandatory.
Yeah.
That facility should have one. A service charter. The Bill of Rights for Patients.
Yep.
That is demanded, right? It's there in black and white.
Yeah.
A nurse can just tell you, stop, no such thing. It's your right as a patient to be able to get this information.
Yeah. Okay. True. I hear you. And you keep saying that, as much as we've talked about all that we've talked about today, is that our health is a personal initiative and responsibility.
True.
What would you say about that?
Very, very true. So it said that you need to pray like you are dying tomorrow, or you are dying the next minute.
Yeah.
But you should take care of your health like you're going to live for 100 years. Yeah, and that should be the mantra. Yeah. Like our bodies are very feeble. You could be in perfect health, running a marathon today, and the next day on a deathbed. So you need to be cognizant to that. And it all starts by being in a good place mentally, accepting that this is something that I need to be. And also, when you ask me what healthcare was, I talked about wellness.
Yeah.
Am I okay? Mentally and physically. So being in a place, realizing that you need to sleep well, you need to be eating well, you need to exercise, have some hobbies, hiking, golfing, whatever, and obviously seek medical intervention when you need to. The issues of self-medicating, that's actually a challenge, and also in our setting, people always, nataka brufen. I'm sure you've heard the story of brufen. Kunya brufen. See the kunya brufen thing, that's a problem. So people need to create habits. We have digital platforms where you can consult online. So just ask. Usikufe hapo, just ask.
Now to avoid Dr. Google, Kenyans are so used to Googling diseases and treating themselves. All right. So I'd say that is it on what we've had to talk about today. Thank you so much for being a part of this conversation.
Always a pleasure, Rachel. Always a pleasure. We've been able to debunk a lot of issues. And, if you still feel you have any other questions, Doc has given you the ways in which you can ask the questions and get the clarifications that you need. But you can always ask through our WhatsApp contact as well, 0721105105, and to make sure that you get the information that you need. Once again, asante for being part of this conversation. We always say that we do value your time greatly. What I would encourage for you to do is that share this conversation, share this link with other people so that they get to understand what they need to understand. It's very important for us to talk about everything else that we talk about, malaria, every other thing. And I've been seeing your questions about malaria. We're going to talk about that. But, it's very important for us to talk about the conversation that we've had today, how you'd be able to access the healthcare that you need. When you're sick, how you're able to get to the doctor, how you're able to get consultation, how you're able to fund. And I know funding, as Doc, you've said, is usually the biggest issue. When you get sick, you're now thinking, what am I going to do? Because, hospitals are very expensive, as we say. But we've talked about that. We said that it's important for you to make sure that you're paying SHA, so that when you go to hospital, you are able to, get treated, as you say, for free, but then you've paid for it. So if you're not paying for it, you might not be able to get the services that you expect. But that said, is that we've had the whole conversation on today's show. So share the link with other people so that they are able to understand today's conversation. For now, I'd like for us to get the Did You Know segment, just to jog our minds a little bit as we wind up on today's conversation. And so the Did You Know today says that, did you know when you give your brain, that when you give, your brain releases dopamine? Okay, the same chemicals linked to happiness. All right, so when you give, your brain releases something called dopamine. And these are the chemicals that are linked to happiness. So when you give, you're happy. So give. And it's not monetary value. Sometimes we talk about giving and we think about money. Sometimes it's your time. Sometimes just, give what you have. Sometimes it's just sharing what you have. Food with someone who doesn't have, an extra cloth that you don't wear. Just, give. It makes you happy. Is that medically That's
approved?
very true. Actually, it's true. Happy hormones, yes, you release. Anyway.
Okay.
It is.
Perfect. So that's what we have today on the Did You Know segment. Again, we are so grateful that we've been able to have this conversation today. And I know that it has changed our perspective. It has changed something. As we always say, is that our mandate here is to transform lives in every sense of the word. And I know that you've been able to do that today. God bless you. Do have an amazing rest of the day. Today being Wednesday, we'll be having our lunch hours from 12:30 to 2:30. So do not miss out. If you're around Nakuru, come, let's fellowship together. If you're not in Nakuru, you know, make sure that you tune in on our socials, that is MBCI TV, and every social media page, that's Kingdom Seekers Fellowship, Apostle John Kimani William. But of course, we'll be live on Facebook, on MBCI TV rather, and MBCI Radio. So do not miss out. Do have an amazing rest of the day. Bye-bye.
Thank you.